Dr. Kaur, it's a pleasure sitting on the stage with you in front of this great audience, but I'm kind of wondering where our news anchor is. I thought we were going to have one of those today. Did you guys see the news anchors earlier?
Unfortunately, I think it's just the two of us for today.
Well, we'll have a good time anyway, right?
I think we will. And again, I just want to kick off the thank you for everybody sticking around. It's been a great day. Appreciate all of the programming from day one. It's been a really great day. So thank you very much. And look forward to some conversation.
Yeah, absolutely. Now, I think a lot of the key learnings that we've heard throughout the day are really you're going to hear some of that come out in our conversation as well. But as a subject matter expert at Aon, a lot of times the work that I'm doing, I often consider myself kind of that puzzle master. How am I taking the data that my clients have, these employers, how do we put it all together and come up with some really good insights? And even more importantly, how do we figure out and identify the right resources really for their members and their employees, right? During one of the most difficult times in their life, and that is when they've had a difficult diagnosis. And whether it's a high-cost claimant or somebody that doesn't have a diagnosis yet, it's trying to get them to the right place at the right time. That really is complex care. Can you talk a little bit more about complex care?
Sure. I'm talk a little bit about our Mayo Clinic complex care program. The short macro view is think of it as a bit of an overlay for primary care. So we know that, as Heidi just mentioned, those rare and unique conditions create tremendous amounts of pressure on your companies with the claims, the expense for healthcare. So in this particular model that we have, it's as I mentioned, it's a bit of an overlay program over primary care type activities. It involves some travel and lodging benefits for patients, and it really allows for equitable and really preferred access to care at Mayo Clinic. Some people oftentimes will ask, well, what are complex cases? What does that really mean? So if you think along the continuum of medical conditions, routine conditions that people see the regular doctor on a frequent basis, those would be more bottom of the pyramid, lower tertiary or lower complexity cares. That's not what we're talking about. It's the things that are elevated up that pyramid of care. Think about rare cancers, rare diseases, challenges where you're not getting answers from your local provider. The threshold for that probably varies a bit on geography. So if you're growing up or live in a small community, your threshold for having a trigger of needing some elevated care is certainly far lower. If you happen to be in a place that has access to specialists or larger facilities, you may still have troubles there because it may be that you can't get access. You may find out that you have a new lump, a bump, a new tumor, new other diagnosis, and you're told that it's going to be several months before you can get in. And then the third grouping of that would be the things that are quite obvious, that there's perhaps only a couple of institutions in the country or perhaps in the world where you really should be seeking out care for those certain types of conditions. Rare sarcomas, rare transplants, face transplants as an example. Just procedures and activities that are really not done at scale at other places where you would benefit from a subspecialty practice like Mayo Clinic.
Yeah, so from the employer perspective, the numbers are small, right? So you're not talking about thousands and thousands of patients in the employer world necessarily for a single employer, right? But the financial and emotional impact of having even one diagnosis amongst your employees can be significant, not only from a cost factor on, if they're in the system and trying to figure out the right diagnosis and so forth, but also that emotional toll of somebody having a really devastating diagnosis and what that impact is on coworkers and so forth and what that brings. So, healthcare in general it can be a very emotional buy, right? So,
absolutely.
I think a lot of times if my kid breaks an arm, I want to get to the best orthopedic place as soon as possible. The same really should be true when we think about these complex care conditions and so forth. And oftentimes, as the employer, we don't get the chance to be able to make those decisions, and we get stuck in a smaller network or have to be in a regional place of care and not always have access to the full scope of experts, world-renowned experts. Talk a little bit more about that and just what Mayo brings to the table when you can offer that as a service to the employer.
Well, I would say that there's a few reasons to consider something like Mayo and consider them early. What we find is that not infrequently patients are referred to us after really that cost curve is already established. The sooner that you can engage with us, the better. So when you're having an employee or when you have a family member that has a routine medical problem, it could be a UTI or it could be any other types of routine medical problem. But when things just don't seem right, that's when you should start thinking about, should I be engaging somebody else? A couple of examples, maybe just very high level, that we see, and they are relatively lower on the pyramid topics. Spine surgery. Roughly 50% of the people that are referred to us have been told by their local family or primary care teams that they need surgery. 50% of them don't, or 100% of those that are told that need surgery that come to us, 50% don't actually need surgery. Another example is breast surgery. So breast surgery, people will think is maybe a bit more of the mid-tier, but we know that roughly 40% of breast surgeries in the communities require a reoperation because of margins or for other reasons that they don't have a diagnosis. For us, that number is 3%. So the numbers can be significantly different, and it can have, a dramatic impact on your care and your costs. Another one is people with MS. So people that come to Mayo Clinic with a diagnosis of MS for a second opinion or review, roughly 2/3 of them are found to either not have MS, to have a different diagnosis, be on the wrong treatment program, to have some other significant dramatic change in either their diagnosis, their therapy, their treatment plans as they go forward. So again, some of these things that even may appear to be sort of mid-pyramid care topics, I would encourage think early, because again, the lower or the sooner that you intervene, the sooner that you introduce them to a Mayo Clinic, the sooner that we can bend that cost curve, get the accurate diagnosis, ideally get those patients healed, and then on their way back to recovery as quickly as possible.
Mm-hmm. I think you have shared some of the compelling examples of really some of the pain points that my employer clients actually mention to us as problems. So, spin in the system where a member might be getting multiple different imaging and diagnoses that aren't correct or treatments that aren't the right course, and what that causes from a cost perspective back to the plan. Lost time, right? So how much time are people spinning in the system without being on the right course of treatment, for instance? Overdiagnosis or over-imaging, things like that. It's just waste. And ultimately, what we really want is getting people to the right place of care and really what is required of them. So, low access to care is a huge problem. We have a lot of places where, providers are no longer providing services. The doctor shortage is a real thing. But ultimately, we need to get our patients, our employees to the right place at the right time so they can truly heal completely. A lot of what I do when I'm talking about strategy for high-cost claimants and these complex care is really running the whole spectrum, right? So it's early diagnosis, it's getting to the right place of care, it's talking about not just the employee odyssey that they're on, right? But also, how are those caregivers taken care of? How are their family members getting support and so forth? Talk a little bit more about the Mayo model and how you guys are really supporting that whole person in this journey and as you like to say, the odyssey. Right?
Sure. Well, maybe before we get to that, a couple other comments that I'll have related to sort of why an academic medical center. So we already talked about accuracy of diagnosis. But a couple of other things that obviously you get benefited from coming to us is many of the care pathways, and all of us I think are familiar with the concept of prior authorization with your health plans and things like that. Many of those care pathways are originated from some sort of expert consensus, national associations and things like that, many of which are actually led by colleagues of mine in Rochester at the Mayo Clinic. What we find is that some of the things that you get preferred access to with coming into our program is access to trials, clinical trials, new innovations, new technologies. A couple of brief examples is radiation oncology treatment programs as an example. So the traditional historic treatment for prostate cancer would be a series of 44 radiation oncology visits. We found at Mayo Clinic that can be reduced actually to as little as 20. So what the impact is to a patient is that they come to Rochester for a 2-week treatment or a 4-week treatment period rather than a 8 to 10-week treatment period. People that have single lesion bony mets, as an example, the standard of care has been 10 therapy sessions. We found that we can get by with 1 if it's a focal localized treatment. So we can have a dramatic difference. Back to your question, Heidi, then about some of the things that Mayo does in terms of how to support families. Number 1, we have something called a condensed itinerary. So I was in private practice for almost 20 years. My experience in healthcare and private practice is that a patient is seen, they have a new lump or a bump, they may have a biopsy, they're told come back in 2 weeks for a follow-up when they get the results returned. When they get the results returned, if it turns out that unfortunately it's a malignancy or a cancer of some sort, then you're told, well, now we need to have you go see an oncologist or perhaps a surgeon. We'll schedule that again in a couple of weeks or 2 or 3 weeks, whatever that time frame happens to be. You have that appointment, now we need to do imaging and additional follow-up imaging. These things can take months. One of the things that's unique about Mayo Clinic is that we take care of patients from over 150 countries, all 50 states. Because of that, we don't have the luxury of telling patients come back every 2 weeks. Those patients are traveling from some level of distance. We're looking at something called a condensed itinerary. So we try to make as much as we possibly can treatment plans that we change really at moment's notice, where you show up on, say, a Monday. Monday morning at 8 o'clock, you may have your visit with a pulmonologist. At 10 o'clock, you're seeing an oncologist. At noon, you're seeing radiation oncology. And all of these things are done in a condensed fashion that we oftentimes are able to see you at the beginning of a week and you're having your surgery and resection of whatever you're there for by the end of the week. The benefit of that, of course, is multiple things. One is the best place for a patient to recover isn't in the hospital, it's back at their homes. The sooner that we can treat the patients, the sooner they can have received their therapies, the sooner we can get them back to home, and then as quickly as possible back to their normal life so that they can resume work, they can resume their normal activities. Additionally, unfortunately, we do have a significant population that come in and they do have very long treatment programs. Transplants are an example. They're going to be in town. We do have transplant houses. We have Hope of Life lodges. We have a variety of other infrastructure. We've got really a robust concierge service that helps the families because we recognize, as you just articulated, this isn't just families. It's not just the patients that is coming for care. It's really the entire family unit, as well as all of the downstream other individuals, whether it's their employers, their other family members. So we have a very robust support system in place to support not only the patient, but the families during this journey.
Yeah. So when I think about, again, strategy development for all of you as employers, again, thinking about, does a Mayo complex care program fit into your ecosystem? And a lot of times the conversation is why not? Having access really to the best in the world, right, is something that is an invaluable option where you have really good outcomes. You listed a few different studies and outcome reports that you have already. But then just from when we think about the sense of belonging and equity and care and so forth is, whether I'm working at a factory in outstate Oklahoma or in the middle of Nebraska someplace or anywhere else where maybe I never thought with a traumatic diagnosis that I could come and have world-renowned services. I mean, it's one of those things where why not, right? And from some of the cost-saving perspective of time, better outcomes, and so forth.
So to your point, there's a couple, again, additional unique models or concepts at Mayo. Number one is we're salaried. So I have zero incentive to see more patients, to do things that inappropriate, to order tests that I don't need. Even the review process. So you're a patient, you mentioned, say, Oklahoma as your residence. You're referred to Mayo Clinic. We review that chart. Some we accept, some we don't. We don't accept everybody. We're not out begging for patients because we actually have enough demand and capacity that we don't need to do that. We've never done that all the way back from Will and Charlie Mayo back in the 1800s when they developed it. That was not the model. The model is it's do the right thing for the patient. And there's really no other discussion that occurs. There's zero pressure on individual clinicians. You mentioned it could be anywhere. We take care of, on any given day, I might take care of a president, a king, some other type of royalty, or it could be a farmer from Oklahoma. It could be a teacher from Rochester. It could be a local individual. So the spectrum of patients that we take care of, the clinicians don't have to focus on that. What they really focus on is, can I help the patient with the condition that they have? If the answer is yes, we figure out how to take care of the patient. If the answer is no, that they're better served local, or if there's no reason that they would need the elevated level of care, then we encourage those patients to stay where they are. So it really is a very unique place that we practice.
Right. I think one of the biggest barriers that my employers have, my clients have, is with any of their benefits, really is about how do you communicate this even exists, right? And so earlier today, we heard a lot of conversation about how to empower managers and people leaders and so forth. And I can't emphasize enough how often I stress with my clients, yes, your people leaders need to know a lot of stuff and be able to guide their teams and so forth. But gosh, if they can have, 5 nuggets of information that are really, really good and powerful about benefits, and how they can refer people into these programs that exist, that all of you are sponsoring and offering, it's a game changer, and how the engagement is and the outcomes, and also that sense of belonging and caring and that whole culture that you're trying to build. This can be part of that as well.
Yeah, agree. Again, I just want to emphasize early. Early is really the key. Frequently, we get asked the question of, when should we send a patient, or which patient do you want? We had a recent exposure or experience with a payer that we were having a conversation with, and they gave us this clinical scenario of a real patient. Diabetic patient, very bad disease, failed transplant, had already had a liver, or had a kidney and a pancreas transplant, had already had an amputation of the lower extremity, already had visual changes, are on dialysis again. Now they're going to have to finally do an amputation on the other leg because it's gangrenous. And the patient is angry. And they asked us then, is this patient yet sick enough for you? And the answer, of course, to that is, well, the patient was sick enough for us 10 years ago. At this point in time, there's very little that we can do. So again, encourage, if you see something that doesn't seem like it fits or something is out of line, we encourage you, again, empower your managers and encourage that interaction at a much earlier side.
Thank you. So as you're thinking about strategy in complex care, again, it's early access, access to the best care, caregiver support, return to work, flexibility, thinking about what it's going to look like when that person returns to work. It's survivorship planning, thinking about what resources might exist for that. And it's also, as Evercare mentioned earlier on the stage, is resources for end of life. Those are all things that have to be considered. Now, I kind of want to wrap up with a quick story about myself.
Please do.
So I wish I could say that I didn't have to know a lot about Mayo, but I did, because my brother-in-law had a very aggressive throat cancer and was treated at Mayo. And the care he was given, not only for himself but his family, was top-notch. My father also had a very rare blood cancer that was treated at Mayo. Again, the journey that my family and the guidance that was given, the efficiencies that were built every time we were in the Mayo, universe down there. I mean, it's just quite an incredible facility, down to the point where, everybody at Mayo is trained to look for people that need help. If you're walking through this giant campus, it could be the construction worker with the hard hat on that says, "Do you know where you're going?" And will practically take you by the hand and walk you to where you need to go. An incredible journey and experience. Unfortunately, those two have both passed on since then, but I cannot stress enough the care that they received, not only for themselves, but also the information that the family received and just the experience in itself. I have another journey coming up. My mother-in-law is going to receive a cochlear implant on May 21st, and she just had her workup appointments, again, all condensed into one day, and it was super efficient. She knew exactly what she was getting, and had all of her appointments, and now has her surgery scheduled. So thank you, Mayo, for your care and all of these patients, And certainly I hope you all learned a little bit more today about why thinking of a complex care solution might be the right thing for your employee population.
Again, thank you for your time. And any follow-up questions, we do have a booth upstairs. Love to answer any questions that people may have. So thank you.